Thank you, Carlos. It's a pleasure to be here. Thank you for the invite and thank you for the introduction. It's very kind of you to add the last part. Thank you so much. And thank you for inviting me to talk about a topic that it's so exciting for me. I'm going to try to keep the talk down to 30 minutes. Laura asked me to present a case at the end, so I put some slides together about the case to present. So I try to do that in the last 10 minutes, and then we have time for questions, I hope. So I'm going to talk about Ollier disease and Maffucci syndrome and some updates that we have from the work that we do in my lab with many other collaborators from other centers in US and outside the US. You can go to the next slide, please. So here is a summary of what was known about Ollier disease and Maffucci syndrome about 12 years ago. We knew that there were isolated cases. There were no familial cases among the patients. And in 2011, when I started studying that in 2010, we didn't have any idea of the molecular basis of these two diseases. And then in 2011, two groups, Amari et al. And Pansuri et al. In Europe, they together published two papers describing the identification of this gain of function variants in IDH1 in most of the tumors that they had tested for from patients with Ollier disease and Maffucci syndrome. And the tumors that they had tested for, most of them were enchondromas. And then they also tested some tumors that were chondrosarcoma, and some patients, they had the vascular anomaly samples, and they tested that. And I'm also just realizing that I jumped right into it, and I didn't even say what Ollier disease and Maffucci syndrome are, just assuming that everybody knows about this disease. So I'm sorry for that. Ollier disease and Maffucci syndrome, they are two rare cancer susceptibility syndromes. They are characterized by these benign tumors, the cartilage tumors called enchondromas, that cause many deformities and can actually be very, very severe in the deformities that they cause, causing leg length discrepancy, or sometimes the discrepancy of the length of the arms, but making the patients to go through many surgeries throughout their lives during the childhood, the young age as teenagers and young adults. And then later, after 25, 30 years of age, they start more susceptible to malignancies like chondrosarcomas, gliomas, vascular malignancies. In general, you'll see in a little bit that these malignancies happen in 50% of the patients. So when they discover in 2011 the variants in IDH1 and in IDH2 in these patients, it kind of made sense because these variants were already known to be have been already been identified in other malignancies like gliomas, like leukemia, and chondrosarcoma itself. That's why these groups actually looked at these variants in these enchondromas, because these variants had been known to be identified in up to 50% of chondrosarcomas of individuals that don't have the syndrome but have isolated chondrosarcomas. But you can go to the next slide. But when that was discovered, we went back to what we had as data and thinking of the disease and think of the variants that they had found. And we thought that there was more to it than just the variants in IDH1 as the cause of Ollier disease and Maffucci syndrome. We didn't think that that was the whole history. And our hypothesis was that there was a combination of variants that were leading to the formation of these enchondromas, and then the happening of chondrosarcomas and gliomas and other malignancies in up to 50% of these patients. And we really believe that it is a oligogenic mode of inheritance, where it's a combination of somatic and germline variants in these patients that were causing the disease. And the germline samples of these patients had not been investigated yet. So we decided that that would be our next step, to actually sequence, and we use whole exome sequencing, whole genome sequencing, the germline samples of these patients to see what other variants we could find beyond these somatic variants that had been found in IDH1 and IDH2. You can go to the next slide. So that is the initial outcome of this work. For years, we went out to collect samples from patients with Ollier disease and Maffucci syndrome. It was real effort that had to be international because these are rare diseases. And while there are many patients, it's not that easy to find them. And by sequencing and analyzing the samples of the paper, we describe about 89 patients, I think, we identified variants in genes that were in the HIF1 pathway in the germline DNA of these individuals. So you can go to the next slide. So here are the genes that we found mutated in these patients: HIF1 alpha, VHL, IDH1 itself, IDH2, but these are germline variants, and they are not the gain of function variants that we already know from the somatic tissue. KDM4C and CDKN2A. They are all related to the HIF1 pathway, and that called our attention, and we found these variants in 22% of the patients. You can see here, found in 21 out of 94. I said 89, but there were 94 patients that we studied in the paper. 14 of them had Ollier, 7 of them had Maffucci, the ones that had the mutation. So we really, if you go to the next slide, we did a statistical analysis, and we saw that if we compare the patients to the controls, we found a difference that was statistically significant between the variants in HIF1 alpha, VHL, and IDH1 among the patients compared to the controls. And that really made us believe that the variants in these genes in the HIF1 alpha, in the HIF1 pathway, are actually in at least these patients, these 22% of the patients that we found these variants on them. This is a second hit that together with IDH1 is causing the disease in these patients. Now, we do have a few patients that we find the combination of HIF1 alpha and IDH1, or VHL and HIF1 alpha in IDH1. And we are now, the last few years, we have been hard working on functional studies to understand the function of these variants in HIF1 alpha, VHL, KDM4C, CDKN2A, IDH1, and IDH2, and also to find other genes in the other 88% of the patients. So that is an ongoing study. We are using CRISPR to model these variants in cell lines. We are using RNA-seq. We are using ATAC-seq. We are using a range of methods, new and old, to try to understand the function of these variants and how they actually impact the HIF1 pathway, and can the HIF1 pathway be a target for pharmacological treatment for these patients. So if you go to the next slide. Now, when we are trying to understand the genomic and the combination of genes and the function of these variants and the pathways that are affected, it's very important to know the natural history of the disease. And that was the thing that I noticed in 2010 when I started working with this disease, that there are not enough papers describing what really happens to these patients. At the time, many patients suggested that they had a higher risk for malignancies, mainly chondrosarcoma, but there was no consistent number across the literature for Ollier, for Maffucci, what else are about, like beyond the chondrosarcomas. So we decided to try to get more information about natural history for these patients. We did a review of the literature, but we also put together a survey that has 90 questions that at this point has been answered by 274 patients. So you can go to the next slide. And these are the countries that you can see. That's a little outdated. The number here doesn't sum up to 274, but you can see that we actually went internationally trying to find patients everywhere to actually get more information about the natural history of this disease in these patients. And add that to the review of the literature that we did to get to our conclusions. And we actually, to find these patients, I would just mention here that we found them by using Facebook. Initially I tried to contact orthopedic surgeons, but everybody had seen one patient, another patient, but we decided that that would not work to us to get the number that we needed. So we went on to actually use Facebook and find the patient groups in there and contact them through it. And that was very helpful, not only for the survey, but also for the genomic part, to be able to collect samples of enough patients to do the analysis that we have been doing now. So if you go to the next slide. That study of the survey and the review the literature, actually, we put together the results of this study in this paper that was published in 2019, and we suggested here some guidelines on how to make the diagnosis of these patients, what tests to do when a patient comes to your clinic with an enchondroma and you are suspecting Ollier disease or Maffucci syndrome, and after that, what to do while the patient is a child, what to do while the patient is an adult, what to do to surveillance for malignancies. So we put all this data together and tried to come up with guidelines, because there was a need that we felt from the patients. They were always saying, like, the doctors never saw Ollier disease, never saw Maffucci syndrome, and they don't know what to do. They don't know how to follow up with us and our disease, and it would be great to have in the literature something that would help them. So if you go to the next slide, and we did that mainly based not only on what we already knew about the deformities and the need for surgeries that these patients have, mainly as a child and as an adult also, but as a child, a lot of the surgeries are for the leg length discrepancy and actually elongating the bones to overcome that. But we actually got to a better idea of what malignancies and what the frequency of these malignancies were in these patients. So you can see here that at the total, we had 286 patients with Ollier, 235 patients with Maffucci. This is putting together the review of the literature and the survey. And in both diseases, up to 50% of the patients end up having some kind of malignancy. Most of them have chondrosarcomas. This is 30%. And then the next most common malignancy in the patients with Ollier is the brain tumor, the glioma, that also happen in the patients with Maffucci, but with a lower frequency, and followed by ovaries and vascular malignancies. So that helped us to decide what kind of surveillance these patients needed, or we thought these patients needed, and also at what age. And I'm going to talk a little bit about that a little bit more later. But I want to just make a pause here. We just had a patient meeting, and you'll see a few slides later. And we have a great team of orthopedic surgeons here at Hopkins in New York that work with us doing these studies and following the patients. And we talked a lot about chondrosarcoma in this last meeting, and how there is a new classification for chondrosarcoma. And the patients with Ollier disease and Maffucci syndrome, they are mostly known to have low-grade chondrosarcoma. And now these kind of tumors are being reclassified and called as atypical cartilage tumors. So that is something that we have now to reassess. It's like, how many percent of these patients have low-grade chondrosarcoma? How many percent of these patients have actually a more severe type of chondrosarcoma? And is there also some guidelines that we should do that are different from the ones that are low chondrosarcoma to the ones that are high risk for more severe chondrosarcoma? How do we distinguish these groups of patients to make different guidelines? So far, the guidelines are aimed to the worst outcome, right? That can happen in many of the patients. But if we can stratify and have different surveillance for different patients with different risks, that would be even better. So you can go next, the next slide. So here is just a table that we have in the paper telling what to do at the time of the diagnosis, later, and later for the cancer surveillance. So you can pass it a little faster so we don't spend all the time in here. You can go to the next slide. I'm going to focus on main points. We can go to the next slide. So at the time of diagnosis, we suggest that these patients should have a whole body assessment. Usually they are young, so you can use whole exome sequencing. We don't really recommend whole body MRI at a young age. The whole body MRI is very useful for differentiating enchondroma from a chondrosarcoma to identify other malignancies, but we don't need it for the identification of the enchondromas themselves, but we do need to know a baseline at the time of the diagnosis, where these enchondromas are, what are the sizes, what they are affecting, so we can have a better idea of what we are going to be following the next few years of this patient as a child or as a young teenager. Can go to the next slide. We also need to, at the time of the diagnosis, differentiate and make sure that we are talking about Ollier disease and Maffucci syndrome. There are other diseases that also have enchondromas as features, and they actually have a different mode of inheritance. They have no risk, no increased risk for malignancies, and we know the genes, and these are germline variants that we can find with a saliva sample or blood sample. So we have to get these patients tested to exclude these other diseases because they have a completely different natural history that has to be followed and investigated in a different way. And as part of our study, you can see that of 268 patients that thought they had Ollier disease or Maffucci syndrome, 30 of them actually had exostosis. And exostosis could be that these patients actually don't have Ollier disease or Maffucci syndrome. They have multiple exostosis, hereditary multiple exostosis. Or it could also be that these patients have metachondromatosis. They can have PTPN11 variants, and in these patients, you see enchondromas and exostosis. So most of these patients had not been tested, and some of them we have tested and found out that they actually don't have Ollier disease and Maffucci syndrome. I think we have this data in a little bit in a few other slides. And also, there were some patients that told us, and I have here one, but we have more now, oh, I have a family history. And when we go after, if there's a family history, we end up finding out that this patient actually has something else. So you can go next. We also do a SNP array for these patients to find out if there are any other chromosomal rearrangement that could be causing extra features, even a secondary disease for these patients. So we do that also for them. You can go ahead to the next one. And one very important thing is the urine organic acid, because that one, if it's elevated in the urine, actually suggests another diagnosis, suggests the diagnosis of metaphysiochondromatosis with D2-hydroxytyrate aciduria. It's a different disease, very, very rare, that we are now delineating better the natural history of that disease. There are only 11 patients described in the literature. We have now 14 that we are about to publish the clinical and molecular characterization of them. But for example, among the patients that we have, these 14, 2 of them are adults and had a chondrosarcoma of the base of the skull. That had not been described in the literature at this point. Of the 11 patients that had been described, there was no description of malignancies, but they were all children also. So we are trying to understand better, but that's a different disease. Also associated with IDH1 variants in the somatic level, but it has a very different presentation. These patients have much more severe presentation of enchondromas. The enchondromas appear in a very early age, around younger than 1 year of age. Sometimes even when they are born, they already have it. And they have all the bones of their body affected by it, both sides, up extremities, lower extremities. So it's a much more severe presentation. And by now, I actually, when I see a patient, I kind of know if the urine organic acid is going to be positive or not. You can go to the next one. And then, as I said, when we make the diagnosis, we do test. We do want an imaging of these patients to know what the enchondroma, where they are, what the size are, and to be following for need for surgery. Sometimes the surgery is needed because it's causing a deformity that's painful, a deformity that affects the function. Sometimes it's because of the leg length discrepancy. So in an early age, the worry of following up these enchondromas is mostly to try to treat the deformities that these enchondromas can cause. Now, the next slide. And then you decide more or less how often you want to do the imaging. But I would say do not go more than 3 years. But the orthopedic surgeon sometimes wants it every 6 months, depending on where the enchondroma is, how fast it's growing, and what is affecting. They will want these enchondromas to be like surveillance on these enchondromas much more frequent than every 2 years. Sometimes they even say every 3 months, I want to be checking that one enchondroma. So that is a conversation for you to have closely with the orthopedic surgeon. But in general, I tell the patients not to go more than 2 years without a whole body X-ray if they are young, to make sure that we know what's going on with these enchondromas. It's also very important to differentiate an enchondroma from a chondrosarcoma, to have that baseline history of the enchondroma. Sometimes you don't know if it's an enchondroma or chondrosarcoma by the X-ray and even by the MRI, and just having the history of this enchondroma documented in the images can be very helpful to decide for surgery or not. You can go next. The chondrosarcoma monitoring will happen in the adult age, more or less about later after 25 or 30 years of age. 25 is the median age for the patients to have malignancies with Ollier, and 30 is for the patients with Maffucci. So we do recommend after the 25, 30 years of age, the patient will start having whole body MRI every year, and including the brain. So you can go to the next slide. Here's about the age. You can go to the next slide. And now this paper is submitted. It was just reviewed, and the reviews are submitted again. So probably, hopefully, will be out soon. The American Association of Cancer Research actually is publishing these guidelines for rare diseases that include bone lesions, and Ollier disease and Maffucci is here, and they actually kind of follow our guidelines also on recommending whole body MRI, including the brain, every year after 25 years of age. So the guidelines that they are suggesting on their paper, they actually align very well with what we had suggested in 2019 in our paper. So now you can go next to the next slide. And I know I'm already getting close to my 40 minutes, but one very important thing is the IDH1 and IDH2 that I want to discuss with you. The IDH1 and the IDH2 doesn't change the diagnosis, right? You just saw that we have the somatic variant in the patients with Ollier, in the patients with Maffucci, in the patients with hydroxyglutaric aciduria. But it is important to get that tumor that is removed, enchondroma, chondrosarcoma, vascular anomaly, tested. And the importance is not so much on the diagnosis, on the management, because we will manage surveillance, follow-up the same way if they find or not the IDH1 variant. But it actually, if you go to the next slide, this paper from 2022, Covino et al. Suggested that maybe the patients that have a higher risk for gliomas are related to the kind of IDH1 variant that they have. All the variants in the IDH1 happen in the same amino acid position. This is 132. It's an arginine change. but he suggests that most of the patients with glioma that he studied in his cohort actually had the R132 age change, 2 out of 10 of them. And that is the change that is mostly found in the patients that have gliomas isolated. So testing the IDH1 variant and knowing exactly what the patient has may be helpful for predicting what kind of cancer they can have. We are still trying to follow up on that data to make sure that this is really something that we can use as predictive. But we need to have the data. We need to have this tested and know exactly what the patients have in the molecular level, in the clinical level, to be able to make this correlation with certainty. So if you go to the next slide, and another thing that is very important now with the IDH1 and IDH2 is a treatment. So the next slide, IDH1 and IDH2, as I said, have been found in many other cancers, and they have been widely studied in the setting of gliomas and leukemias. And they were, FDA just approved the use of IDH1 and IDH2 inhibitors for patients with leukemia and gliomas. So the first question that came to mind is that, does this medicine also help the patients with Ollier disease and Maffucci syndrome? And we are in early stages of talking to see if we can set up a clinical trial for these patients with this medicine. And some patients in Europe are actually taking this medicine for the indication for glioma and chondrosarcoma. They have Ollier disease and Maffucci syndrome, and we are learning a little bit of the response of this patient. And we are using this information actually to maybe guide a clinical trial for this patient. But if we are going to have a clinical trial, if this medicine is going to be used, we also need to know if these patients have IDH1 or IDH2. So again, it's important that if the patient have a tumor removed, to know if the IDH1 or IDH2 variant is in there. So next slide. That is a paper that just came out from a group in France. They described one patient with Maffucci that they have been giving the medicine for the indication of glioma, and how the patient has been responding. And the response has been overall actually very good, and actually kind of like motivating us to really investigate the use of this medicine with a clinical trial. So we are actively looking to that right now. I think I have other slides and I had more things to talk about, but I think because of the time, I may just share one clinical case with you all and then go for the questions. Is it
Nara?
okay? Yes.
No, absolutely. Absolutely. This is your day.
Okay.
Yeah.
Do you want me to finish the slides or to stop?
No, you should finish your talk and
Okay.
present your case. That would be just great. We have had a offer of a rare case also to discuss. I just want to let people know, which we hope to add on today. But we're going to just see how it goes. This is your day.
Okay, thank you.
And I'm sorry you're feeling rushed. That wasn't the plan.
Please.
No.
Okay.
Yeah. This is such a fascinating story in terms of how you put this together. Thank you.
No, thank you. Okay, so let's go to the next slide then. So the other thing we wanted to investigate now continue on the clinical natural history of the disease is like, are there other features that are part of these syndromes? Like many patients will come to me and say, oh, I have this symptom also, I have this feature also. And we don't really know if that is just a rare manifestation of the disease or if it's just that the individual has something else going on. So we started also as part of the survey trying to get this information. And we have, of the 268 patients that answered the survey at the time that I had done that analysis, 27 of them had described developmental delay, 13 had described intellectual disability, 42 had described scoliosis, 47 had described teeth anomalies, and then 98 of them had other things, including anemia, thyroid disease, hypoparathyroidism, and osteoporosis. So these are very important features, and we want to determine if they are part of the disease or if they are separate things. And things here that come up that are very interesting for us to follow up on. For example, the anemia. The anemia is highly related to the genes that we have found in the HIF1 pathway, VHL, autosomal recessive disease that causes an autosomal recessive disease that causes anemia. And is it related to our patients and the VHL variants? So that's one of the things that we want to explore. The other things, like one of the genes that had been suggested as cause of Ollier disease and Maffucci syndrome a few years ago was the PTHR1, and is this thyroid or hypoparathyroidism has any relationship with variants in these genes? And then osteoporosis, like, do these patients have osteoporosis or osteopenia as part of the disease? Is it something that we should expect? This is very important for us to know, because you probably know, for example, of the clinical trial for the patients with multiple sclerosis that was canceled because they thought that the medicine was maybe causing premature closure of the growth plates. And at the time, nobody knew if it was maybe because of the medicine or if it was part of the natural history of the disease that nobody had actually described very well. So we need to know these things. And as part of understanding better these features, we were awarded last year a UO1, that is a collaboration with NIH, to do a natural history study at NIH, and we are going to bring 100 patients with Ollier disease and Maffucci syndrome to the NIH, and NIH cover the cost of these visits. That's similar to a study that has been done for melorheostosis. And we are going to have these patients to have clinical assessment by many different specialties, imaging of all kinds, blood tests, urine tests, molecular testing, and we are also going to do analysis of the bone metabolism with DEXA and other studies that the PI at NIH is actually started as Dr. Marini, but she retired, and now it's Dr. Gordon. Dr. Gordon is an endocrinologist, so she's going to be helping us to understand also the bone metabolism of these patients. So that is important, because if we want to actually do a clinical trial for any medicine for these patients, we need to have a good understanding of the natural history of these diseases, so we can get to choose the right endpoint and be aware of what is part of the disease and what could be a response to the use of the medicine that maybe a response that we don't want. So if you go to the next slide. And that is very important for us to do, is to separate what is part of the disease and what is a second diagnosis for that individual. So you can see here that among the patients that we have investigated at this point, we have found other things. Patients, we know that in general, in genetics, up to 4% of the patients have a dual diagnosis. They have two diseases going on. So that can happen also with the patients with Ollier disease and Maffucci syndrome. And here you can see that we have patients that have Down syndrome on top of Ollier disease, patient that has a susceptibility to amyotrophic lateral sclerosis, patient that had an autoimmune polyendocrinopathy syndrome. This patient, it's a patient that has 3 other diseases. She has a CHEK2 pathogenic variant. She has hearing loss. We found a gene for the hearing loss. She's a carrier for this deletion on chromosome X that's actually associated with a X-linked recessive severe congenital ichthyosis. So this patient had 3 other things going on top of having Ollier disease. And I had a patient also who came to us. She had a family history of neurofibromatosis, and she didn't know if she had neurofibromatosis also. What was the relationship of her diagnosis of Maffucci with the history of neurofibromatosis in her father and her sister? Turns out that they had 2 different things going on. We found the neurofibromatosis mutation for her father and her sister. She didn't have that, so we were able to dissociate these 2 diagnoses in that family and clarify what was and what was not part of her own disease. So this is important, as you saw in the first slide, to know what is part of the syndrome and what could be caused by some of the genes that we think are involved in the syndrome or not, from what is a secondary diagnosis, something completely different that is just happened to happen in this patient also. So if you go to the next slide, I think I'm almost done with these slides. That is a very interesting paper that was actually led by a patient with Ollier disease in Italy. And Italy has a patient group that's very active, and this Otto David, he's actually now doing a PhD, also studying, he's studying multiple exostosis, but he also wants to end up studying Ollier disease and Maffucci syndrome. And he did a very interesting study. If you go to the next slide, I told you that in the childhood, the patients are very worried about, or we are very worried about the growth of the patients, the deformity, the limb anomalies, that deformities that can happen because of the enchondromas. But then on the older age, the disease change, and we are more worried about the malignancies. So he was very interested in that transition. What is important for patients, for healthy caregivers, for affected caregivers, and for the healthcare providers when we are going from this transition from being a child patient to an adult patient. And they had focus groups in a patient meeting that I participated 2 years ago, and they discussed these different topics in each one of the topic in these small groups to come up with this graph that you see here. They talked about psychological support, transitional visit, empowering young patients, digital health records, and a more understanding and empathetic clinician. These were some of the topics that came up as priority for the patients, for example, but they all repeated themselves a little bit among the other groups. But you can see that for the patients, psychological support was very important. They felt like they needed that support from going from one phase of the disease in their life to the other. And then it was also important for the healthy caregivers. The affected caregivers were actually more interested on better communication with clinicians and empowering young patients. And then the healthcare providers were also more interested in better communication with clinicians and define care. The healthcare providers really care about having some guidelines so they can follow and know exactly what to do. And that's what we hoped to help with when we wrote the paper in 2019. And I think the AACR paper is also going to be very helpful because it's going to be something that's not from this one researcher lab. It's actually something that's coming from the AACR. It's a bigger group of individuals coming together and agreeing on a guideline for these patients. So I think that will help a lot with that aspect of the concern that the healthcare providers had. So if we go to the next slide. Here is a picture of us last year when we had the first patient meeting, 2023. You can see Carlos is here also. Carlos and I have been collaborating on trying to understand better this disease. Carlos has been working a lot on the IDH1 and IDH2 part of the project. So it's a pleasure to work with Carlos, and thank you for inviting me here today, Carlos. But if you go to the next slide, this is the patients actually have a website that they started working on a year or two ago. And as I said to Laura a little earlier, we don't have a US patient association or foundation. We have been trying to actually get that done, and it has been very hard for the patients. I think a lack of understanding of how to get that done, and also a lack of time. That's something that is time consuming, and you probably patients, if there are patients here, know what I'm talking about. But we are trying to get that done, and part of the having this meeting last year and this year is actually to get these patients to know each other and to get together and talk more about their needs, and maybe organizing some kind of something as a society, a foundation, association. Go to the next one. I think the next one is just showing that we just had the last one, the second one now, October 26. It was also about 60 participants, actually 70. We had about 40 people in person, about 30 online. So it's a large number of patients for such a rare disease. And we just started having this meeting here in US. So we are very happy with it. And if you go to the next slide, I think I have the acknowledgments. Yeah, and I'm very happy with that acknowledgement page, because when I started talking about Ollier disease and Maffucci syndrome, I didn't have a lot of things to put on the acknowledgement. I didn't have a lot of people collaborating with me, working with me. But as I kept working on it, I was fortunate to have many very good people as students or all the faculties, all the specialties that got interested on it and are working with us now. So you can see here that there are many people. Some of them are orthopedic surgeons, some of them are researchers in Hopkins, some of them are researchers at NIH. The UO1 that I told you put together many researchers at NIH, not from different branches. We have Dr. Gordon from NICHD. We have Dr. Stewart from NCI. So I'm very fortunate that a lot of very, very good people have been getting interested to join and collaborate and study more these diseases, so we can get to a better answer to the patients and hopefully to a better treatment.